Hello, welcome to episode number 6 of STA Extra. Today I've got with me Mark Nussey, who is a regional rep from East Anglia, and he's going to be talking to us about cardiac rehabilitation. Mark, welcome. Thank you for joining me today. Take two on this after I didn't hit record. So yeah, thanks for joining me today. So kind of just want to hear a little bit about your background, how you got started, and little bit about how you got into the STA and your background as a sports massage therapist, really. So thank you, and over to you.
Okay, well, short version really. So I went through high school in the 1980s and absolutely hated it. I hardly ever went, if I'm honest. So I left school with a £25 bill for not turning up for my exams, no qualifications, and ended up going in the Royal Air Force as a regiment gunner. And then in 1993, I was in a helicopter crash, got some back injuries and hip injuries, went through the rehab process in the RAF, but then was medically discharged in 99. But that meant that I could get qualified in whichever area I wanted to go into. And I figured that the health and fitness would be the best way for me to go. So I qualified as gym instructor, personal trainer, except level 3. And ended up managing a local authority gym. Then in 2002, I was seconded to the local primary care trust as the coordinator for the exercise referral scheme. We had numerous gyms and facilities that we would use, and there must have been within that 18 instructors that we used. The NHS got some money to do phase 4 cardiac rehab, which is the community end of cardiac rehab. And I pushed it out to all the instructors, but none of them wanted it. And I'm a bit of a sucker for free training, so I grabbed it with both hands. Yeah, and away we went. So 2005, I qualified as a phase 4 instructor and ran it at the local leisure centre and community centres. 3 classes a week, I think, at that stage. And because of the nature of cardiac rehab, you have to have close connections with the cardiac rehab team. And eventually they contacted me and said, well, I'd like to run the phase 3, which is the hospital-based, or it was hospital-based, it's now in the community, but it was hospital-based. And that was 2010. So I was running phase 3 and phase 4 cardiac rehab. So probably about 6 or 7 hours per week. And that was alongside my other stuff. I was doing spinning, circuit training, crew class, aquasize, step, pump, the whole lot. And I got to 40 and I thought, I'm getting tired every week and just falling asleep and everything else going on. So then I decided I need an exit strategy. So I went to London and did the level 5 IRSM course, sports and remedial massage course. Set up my own clinic, reduced all my classes apart from cardiac rehab, and I'm only doing probably 3 step classes a week now, aquasize and circuit, but nothing too much in my own clinic for about 15 hours, I would say, a week. I joined the STA about 5 years ago now, I think, at Holcombe. I met Gary up at Holcombe doing the triathlon up there. Met Gary, and I was with another body at the time, and they just weren't doing anything for me. The only time they were contacting me was basically when there was renewal. So I met Gary at Holcombe and immediately, got a connection with Gary and just thought, I just need to change. And that's what we did, went there. So the cardiac rehab now, I'm running phase 3 and phase 4. Yeah. Love
Interesting stuff. It's I imagine it's quite different to the background of a lot of our member base, really. So I don't really know anybody else off the top of my head who's doing your kind of stuff.
Yeah,
so it's interesting.
Amazingly, anybody could get involved. If they're level 3, at least level 3, they could get involved with it. And not everywhere in the country has it. And it's just getting in touch with the local cardiac rehab team and getting, their recognition and getting their backing, and yeah, just go ahead with it. It's just like a normal class, really.
Yeah.
Apart from the fact that you need a referral.
Yeah.
So yeah, if anybody wants to get involved with it, just get in touch with your local cardiac rehab team and find out if there's a market. We're looking at facts of that. There's 2.3 million people in the UK that live with coronary heart disease at present. And every 8 minutes, someone dies from a heart attack. Which is,
wow.
Wow. It's yeah. So and every 5 minutes, someone is admitted to hospital due to a heart attack. Every 5 minutes is like incredible. When I was researching it, I was like, wow. Now, back in the 1960s, 7 out of 10 people who had a heart attack, they were fatal. Now, at least 7 out of 10 survive.
I suppose it's wonders of modern medicine, isn't it? And kind of modern research. It just kind of shows there. It's a complete swing, opposite way. So I suppose that kind of just shows changing attitude, changing.
Well, I think that's
treatment.
down to the how quick they're getting in now, and I think they're looking. I think the latest stats they're looking at stenting people, which is putting an opening into their arteries within 3 hours of heart attack. Now, so they're in the ambulance, they're getting thrombolized on the way to the hospital, and then they're in surgery within 3 hours. I think that's what they're looking at now.
Wow. I'll be honest, I didn't realize it was that quick. I thought it was kind of you've had a heart attack, we're going to put you on a waiting list. I didn't realize.
It depends on the heart attack, really. I mean, if it's a minor heart attack, you might get away, but if it's a full blockage, then yeah, you're looking at needing stenting straight away. And that's what we're looking at. And then looking at that, 1.4 million people in the UK have survived a heart attack.
That's 1.4 million people currently living now.
Yeah, in the UK. Yeah.
I mean, I don't want to kind of put the recent stuff, but you look at those figures and it kind of puts it into perspective a little bit, doesn't it?
Yeah.
Kind of all the kind of stuff that we've been going through over the past 18 months. And then you look at that, every 5 minutes, somebody has a heart attack.
Yeah.
That's massive.
Cardiac rehab is a whole process. So it's lifestyle, it's exercise, it's diet. Coronavirus is just because people aren't presenting now. Where people, if they had minor chest pains, they would maybe go to A&E, but they haven't been doing. So I think the incidence of heart failure have gone up by about 30%.
Wow, because people aren't attending with their initial.
No, because they're not going with like I say, with chest pains or anything, breathlessness, they're just not going because of COVID. So it's we're only just now getting back to face to face.
So how's your kind of work changed over kind of the past 18 months then with COVID? Has it gone up? Has it gone down? Is it kind of?
No, it's gone down. I haven't done I'm only just now back to phase 3.
Okay.
But what I did right at the start was I got as many low risk people as I could to sign up to a Zoom class. So I was doing phase 4 via Zoom, but I could only do low risk people. And the stipulation was they had to have someone with them. They had to be medicated and they had to be stable. Otherwise I couldn't take them. And I ended up with about 11 or 12, which I've been doing on a Monday and a Thursday. It's about a year now, actually, thinking about it.
So how many would you have seen if you in a pre kind of COVID times in a week?
15 per class. The ratio is 15 to 1 in phase 4, 5 to 1 in phase 3, and possibly 3 to 1 if they're high risk.
Okay. So what's a class generally look like for you? So if you take that kind of the Zoom class kind of thing.
So the Zoom class would start. I start them at 9:30. We would go through any medication changes with them. They would look at any changes in breathlessness, chest pains, any other thing like that. If everything was okay, we'd then have a bit of a chat for the next 5 or 10 minutes. We'd start the class, which is kind of circuit based. So I would do 2 minutes of something like marching on the spot, hands to knees, elbows to knees. So quite high level for them, followed by a minute of what we call active recovery. So then something still keeping their feet moving, but doing something like light bicep curls or something like that. And that would go on for about an hour's class.
Okay. Oh, so it's quite a long time then.
Yeah, it's not like we're sitting them down and not doing anything, doing as little as possible. No, it can be quite intense for some of them. And now actually looking at some of the research they're doing now, they're doing that HIIT classes in some of them with some patients. So a minute
Right.
really hard HIIT, yeah, high level, and then a minute's rest. And they found, it's pretty comparable with
So you
cases.
kind of lessen the time kind of actually worked, but kind of
more
keep the
intense.
benefits. Yeah.
Yeah, absolutely.
Have you used that yourself, or is it?
No,
Have you kind of stuck to the traditional?
I'm not sure I would. Not at the moment, no. Because I was only recently that I saw that, and I thought, oh, I don't know whether I'd be doing that at the moment, especially with me not being there.
Yeah.
Because I've had a couple of incidents. I mean, in what 17 years I've been doing it, I've only had a couple of incidents, but I needed to be there to know.
Yeah, I imagine it's quite intense, quite scary if anything happens in that situation.
When you see someone's eyes glaze over, and it can be a bit twitchy, to say the least. So there, we do an hour, and then we do a cool down, and then I have to have a chat with him for about 15 minutes, because you have to observe them 15 minutes, follow exercise, just in case there's any arrhythmias or anything like that. So I do that Mondays and Thursdays for Zoom. I've just started back at phase 3, and because of the amount of people that are waiting to come in, I'm there all day on a Tuesday at the moment, 9 till 4, just assessing people at the moment, which why we do chest to step tests, we do observation tests on them, medication checks, and we do resistance with them in a view to them coming into a phase 3 circuit. So
I imagine it's intense, but I imagine it's quite rewarding as well.
Yeah,
because it's a whole life. It's not just kind of, if we get people coming in with like injuries and stuff, and we help them, and that's a rewarding job. But I suppose to a degree yours is similar, but I suppose it's life changing for some people.
Yeah, well, I've seen some people, they come in and they're petrified to do anything. They've stopped absolutely everything, which, as we know, is the worst thing they could possibly do.
Yeah.
So it's about getting their confidence back and getting them moving, really, and seeing them at the other end. I mean, I have seen, going from the extremes, I have seen people coming in scared to do a bit of walking, but by the time they've gone through the rehab, they're jogging around comfortably, and happy with it, and their facial changes and their whole demeanor changes. It's good. The phase.
So how do you? Sorry, go ahead. The phase 4.
Phase 4. The guidelines say you should have them for 15 weeks.
Okay.
And move them on. Pre-COVID, I had someone in there that had been with me 14 years.
Wow.
There was nothing appropriate for him to move on to, and I didn't want to, because he would go home and do nothing, and he admitted that if he didn't come to the class, because with the other 15 people, it's a bit of a social thing as well. And he admitted that from there he wouldn't do anything. He would just sit in the chair. So kept hold of him. Didn't tell anybody he'd been there for 14 years. But don't know.
Yeah, I suppose I've used that kind of. I mean, as therapists, we kind of, we want people to kind of self-manage. We don't want people to become reliant on us.
Yeah.
But sometimes, I'm a massive advocate of exercise rehab and just getting people moving for certain things. And it's the same sort of principles across the board for cardiac rehab, people in pain. If they don't do it here, sometimes no matter how much motivation you give them, just will not do it at home. They're not going to go to a gym.
No.
So if they want to come and see me every week to do half an hour's worth of exercise, and it helps them with pain, but it helps them actually stay fit and healthy, I'm happy to do that.
Yeah.
It's
definitely.
So it's 14 years is a long time though.
Yeah, but looking at this patient
That's longer
group,
than I've known most of my friends.
looking at the patient groups, they're just, traditionally they haven't exercised, which is why they're in the position they are. I mean, don't get me wrong, we do get some people that are coming through that are really fit people that have just got mechanical issues like valve problems. And I saw a guy yesterday, he was a fireman and he needed a valve replacement and he was gutted. I think he'd done the London Marathon the October before, didn't realize why he was so breathless, and it turned out his valve was faulty. So it's changed his life again because he now realizes that he's been running with a faulty valve. He's back to where he was really, and he's just interested to see how far he can go now.
Yeah. So
if he's doing London Marathon with a faulty valve, what could he do?
I know.
With one that's decent.
To be honest, I mean, God, touch wood, I don't think I've got any faulty valves, but I don't think I can do that. I know I can do the London Marathon.
Yeah. So we tested him yesterday, and he completed the Chester step test. Couldn't go any further with him. He was going as fast as he could, and his heart rate was nowhere near where he could have been.
So it's just, so what do you do with him?
Well, he's trying to get back to work because he's been signed off from work. They wouldn't let him back to work until he'd gone through rehab. There's nothing we could do because he would pass his functional test for the fire service, no problem.
Okay, all right.
So he doesn't really need rehab. He just needed to be told that he was okay.
So it was more of a kind of reassurance.
Yeah. So he came in, had the test.
I suppose there's a lot of other things in that job. I mean, there's obviously like physical and mental stresses, which will obviously play a huge part in kind of his situation, I suppose.
Yeah, he'd had the valve replacement. I mean, but they'd cracked his chest as well, so he had a sternum wound. They put him on beta blockers, which slows his heart rate down. So there's a lot of things going on which he didn't have before. So I think his work and he needed the reassurance that he was okay to do whatever he needs to do. But yeah, I think he's going back in about 6 weeks to work, I think. So,
wow.
Brilliant. And that's what he's only had surgery 6 weeks ago.
Wow, that's quick, isn't it?
I know. Yeah.
That's pretty quick.
Yeah. Yeah, he's not allowed to swim for 6 weeks, for 12 weeks, but he can go back to work in 12 weeks' time.
Okay. So he can go into. He's got to be on reduced duties at that kind of thing, surely.
Well, you'd like to think so, wouldn't you? But seeing him yesterday, I think he would be okay to do his job. The only thing stopping him at the moment is obviously his chest wound, so he won't be able to do his lift tests. But his cardiovascular work is, he'd be fine, I would think.
Wow. So I'm just quick because we kind of got off the beaten tracks. We just start discussion. Do you want to kind of go back to your presentation a bit?
Yeah.
I'll rudely interrupt you again.
So you might hear different phases in when you talk about cardio, like coronary heart disease, coronary artery disease, ischemic heart disease. They all mean the same thing. Yeah, okay. People think they mean something different, but they mean the same thing. And I've got a video now of what most people come and see us about. It's atherosclerosis, which is the stuff that causes the heart attacks. I've got a video on that, so I don't really want to put that in later.
Your arteries, a system of tubes that transport blood around your body.
I'm trying to make that bigger.
The buildup of fatty material can damage and clog arteries, restricting the blood flow. This is known as atherosclerosis and can lead to heart attacks and strokes. There are several causes, including high cholesterol, which can clog up your arteries over time. High blood pressure, which can damage areas in your artery walls, making it easier for fatty material to build up over time. And smoking, where chemicals in tobacco smoke can also damage arteries, leading to this fatty material buildup. If a fatty deposit breaks down or ruptures, a blood clot can form around it. This can block your artery. If this artery supplies blood to your heart muscle, it can cause a heart attack. If this artery supplies blood to your brain, it can cause a stroke. There isn't a cure for atherosclerosis, but thanks to British Heart Foundation research funded by your generous donations, we are understanding more about how to treat it. The good news is that you can do something to slow down its progress, and the earlier you start, the better.
Part of the, so someone has symptoms, they then will go for some investigations. Some of them you would have heard of. So we've got an ECG, which you've all probably heard of. So that will check for heart rhythm. You can diagnose an MI from that. Then we've got an exercise ECG. So it's the same kind of thing, but what they do is they put the person on a treadmill, and then what they're trying to do is they're trying to provoke some ischemic response, and it can check for any blood pressure response as well. It's also echo that you might have heard of. With the echo, they're looking at the function of the left ventricle, how that's pumping, the size of the chambers around the heart, the thickness of the walls around the heart. What else? The competency, how the valves are working, if they're working, open and shutting properly, and any presence of any other abnormalities. And the other main one is an angiogram. So basically, what they do is they put dye in, they put a catheter up, and they check for any blockages in the arteries, so they can tell from that any locations or degree of blockage, so whether it's full thickness or just a partial block, and they can also probably identify the best treatment for that, whether that's going to be bypass, medication, or a stent. So basically what the stent is another catheter is fed up. It's got a balloon on it, and around the balloon is like a wire mesh. They take it to where the site of the blockage is, and then they inflate it. And then the wire mesh fixes itself to the artery walls. They deflate the balloon, and hopefully the wire mesh is going to stay and keep the artery open.
Okay.
Does that make sense?
Yeah.
So the balloon, wire cage.
Yeah, I'm picturing it in my head.
Opens the artery. The wire cage then embeds itself into the artery wall and keeps it open. They've also got balloons that they inflate, and around the balloon they coat it in a drug that then, when it inflates, it again keeps the artery open.
Ah, right. So it's literally administering to a very specific spot.
Yes, it's where the site of the blockage, that's where it is. And they're also doing now, they're passing a little tiny drill and drilling out the plaque and the artery. So yeah, it's amazing. It is amazing with the stuff they're doing now. But they need these investigations to find out what is going on. And that's just a few. There's other MRIs, there's quite a few other investigations they could do, but that's the main ones. The main things that we get through in cardiac rehab are unstable angina, what they call it, an ST elevated myocardial infarction, so a heart attack, and a non-ST elevated myocardial infarction. And the difference between the two is what comes from the ECG. I'll put a picture up of the ECG. And if you see it, there's a segment that's between S and T. Now, if that's elevated, if between S and T is elevated, that's indicating a full blockage, myocardial infarction. Okay. And if it's not elevated, that's indicating a partial blockage. If that ST section is decreased, that's indicating unstable angina.
Okay.
So you can tell a lot from the ECG, but what they'll also do is they'll also do a blood test. What the blood test is doing, when you have a heart attack, a protein called troponin is released into the bloodstream. So the increase of that protein then indicates that there's been a heart attack, and the level of the heart attack. Obviously, the more protein, the higher degree of heart attack. Okay, so if you can imagine a blockage in the artery around the heart, the longer it's left, the more of that heart tissue is going to die.
Yep.
Yeah, so that's why they're trying to get them in as much. Even if you've got a full blockage, if it's opened up quick enough and we get the blood supply back to that tissue, you're going to get as much function back as possible. Yeah.
Interesting.
A lot going on. So
there is. I'll be honest. It's not something I've kind of, I've done it historically, like little bits and stuff, but never in this depth. I find it fascinating. Like I really do, because it's, I'm learning loads just from this.
Yeah, no 2 days are the same. I don't think I've ever gone in and it's been boring. It's not. It really isn't. There's lots of things going on. I mean, those are the main ones we see, but we also see valve replacements. We see people who have pacemakers fitted, or internal defibrillators fitted, and something called an LVAD, which can be an external or an internal pump. If you can imagine this external, basically it's a pump on the outside of the body. There's tubes from that are basically doing the pumping. So the tubes are going into the body, doing the pumping, and coming back out again. I've never seen one yet, but there are rehab units that are seeing them. And so they put an LVAD on people while they're waiting for transplant. That's
right. So it's kind of a precursor. It's kind of like, this is here. This will keep you alive until we can.
Yeah, it's keeping the blood working and going round while they're waiting for a transplant. But there are people that have gone through rehab with an LVAD, and then they've not needed the transplant.
Wow. So they just carry on living on with a device.
No, the device is then removed.
Oh, right. It's gone.
Yeah, the rehab has been enough to help the heart back into activity, and the LVAD's been removed, and they've not needed the transplant.
Wow.
Yeah.
And I'll be honest, I just assumed once you needed a transplant, that was it.
It depends what they need a transplant for. There has been. I mean, there's also been cases of people have been waiting for bypass, but the body has done the bypass itself. It's rerouted the artery, and then they've come to bypass, and it's already done the job.
Wow,
the body is amazing.
Yeah, it's pretty amazing, isn't it? Wow.
Yeah. So the other thing that comes with the rehab is medications. Now, as you can imagine, there are thousands. The groups, we've got ACE inhibitors, we've got alpha blockers, we've got receptor blockers, we've got antiarrhythmic drugs, we've got beta blockers, we've got antiplatelets, anticoagulants, calcium channel blockers, lipid lowering drugs, nitrates and diuretics, potassium channel activators, and cyanide inhibitors. Now, what all these are doing, they're either slowing the heart rate down, they're increasing the diameter of the arteries, they're increasing the conduction of the electricity in the heart, or they're bringing down the blood pressure. That's what all these are doing. So patients could come with all of them or a few. So a part of my job is to work out what's going to be affected during exercise. And the main one that comes to mind is a beta blocker, because that will lower the heart rate. So their threshold is lower. But that was
going to be my next question. When I'm just looking at kind of the medications there and just going, I imagine there's so many different indications, contraindications, and stuff for each of these that you have to take into account and kind of plan around.
Yes, it's not so much contraindications. It's more about what we can expect to see when they're on that medication.
Precautions more than.
Which is why when we go every lesson, we have to go through, has there been any medication change since we last saw you? Because there's going to be an implication of that, if there is. And we don't always know, depends on how long we are between seeing them. If someone says they're going away on holiday and then come back and they say, in the meantime, I've been to see the doctor and they've taken my beta blocker away or whatever, that's an implication. So we have to look at that. And it keeps on.
That sounds like a minefield, that one.
And now I've just coming on to the phases of cardiac rehab. So we've got 4 phases. Phase 1 is the inpatient stage, where they're in hospital, they're having the procedures done. Some of them don't. Some of them go to phase 1, they have the bed rest, and then say in 2 or 3 weeks' time, we're going to bring you back in for your stent, or depending on the degree of what's gone wrong. They'll then be discharged to phase 2, where they're then under a cardiac nurse, and the cardiac nurse will go through medications. They will go through any lifestyle changes they think they can implement straight away, and that's probably 6 weeks in phase 2. Just checking because I did write it down. Yeah, about 6 weeks in phase 2, and then they'll be invited to phase 3, which is, it used to be in hospital, but around here, and it may be in hospital around the country, but around here it's been moved into the community. So phase 3 is an exercise program, and they have education on diet, home programming, any other lifestyle changes we can go through with them. Obviously, exercise is going to be a high priority. So looking at a home program, what they can do outside the rehab, and they'll be there for 4 or 5 weeks doing that. In phase 3, we've got 2 cardiac nurses, an occupational therapist, and an exercise specialist. So plenty of people to keep eyes, because like I say, the ratio is 5 to 1, maybe even 3 to 1 if the patients are high risk. Pre-COVID, we were looking at 12 patients in phase 3.
Okay.
Now, I think we're looking at 6 now.
Oh,
just
okay.
spacing. Yeah, because even though Boris has got rid of our precautions for COVID, they've decided, as we have with the STA, is just keeping all the precautions in, really.
To be fair, it's probably not a population that you want to be taking risks with, is it?
No, exactly. So yeah, we wear a mask spacing the whole lot. So in phase 3, they will come in, they'll do their OBS every time, blood pressure, heart rate, any medication changes. They will do a warm up, and they will do a circuit, be a smaller circuit, and they'll be grouped into probably 30 seconds high intensity, 1 minute active recovery. Then there'll be 1 minute high, 1 minute low. So that'd be very low risk, really. And some of them, at the start of phase 3, we'll exercise test them. So we'll either do a chest-to-step test, a incremented shuttle walk test, or a 6-minute walk test. And that's decided by the nurses. They'll decide what test depending on their OBS that they've done with them. So at week 1, they will do that test. And they will also do a resistance test. So we'll see, because part of phase 3 is at the end of the circuit, they do a bit of a resistance program. And it's bicep curls, front shoulder raise, squats, or sit to stand, whichever they can do. So at the end of the 4 or 5 weeks, we do another test, and hopefully they've made some improvements. And they generally do make some improvement on the baseline test that they do. We don't see many 6-minute walk tests, got to be honest, because if they're down to a 6-minute walk test, they're not very stable, so they're not appropriate for the phase 3, because they generally need to be stable on their medications. Following the 4 to 5 weeks, they're then pushed out to the community onto phase 4, where they could be 15 weeks or 14 years.
14 years under the radar.
Yeah. And I mean, again, depending on the area that you're in, I don't think there would be an issue if there's enough people coming through the service to have 4 or 5 different phase 4 instructors. So again, I think if anybody's interested in doing it, but really contact, the first port of call would be their cardiac unit to find out if there's a requirement, and then do the training, because I love it, absolutely love it.
Yeah, I imagine it's very, like I've said before, I imagine it's very, very rewarding, because like it's literally potentially saving somebody's life. It's it's very different mentality kind of outlook to what a lot of us are used to.
Definitely changing someone's life massively. Definitely changed it. Yeah. Whether it's saving someone's life, yeah.
I think you probably, if you say no, I think you're probably doing yourself a bit of injustice, because if it's the same in a lot of kind of therapy industry stuff. They've got to buy into what you do.
Yeah.
Some people, if you don't change their mentality and get them to buy into what you're doing, then because it's not, once that phase 4 bit stops, unless they stick with you for 14 years and they kind of go off on their own, they need to know to make these changes and kind of be confident to make these changes and have a positive experience.
Is trying to find someone to push them onto.
And
when I did my training in 2005, the stat was, once you've had an event, if you don't exercise following that event, you are 40% likely of having another one.
Wow, that's high.
Yeah, that was back in 2005. So whether that's changed now, I'm interested to see if that has changed. Yeah, 40% chance of having another one if you don't exercise.
Wow, that's. Is it cup half full or cup half empty?
Well,
but that's what I mean. It's kind of like some people go, but I've got a 60% chance of surviving. I'd rather just go for a walk, to be honest.
That's all it needs. It doesn't need to be a gym. It just needs to be that that moderate activity.
How many times do we have that conversation with somebody? It's not all about lifting weights, going for runs, doing HIIT circuits. I mean, where I am, I'm literally 5 minutes away from the seafront. There's a big long promenade. Just go for a walk down the beach.
Yeah, that's exactly where I am. I'm on the seafront at Lowestoft.
I use that kind of setting quite a lot. I've got quite a lot of elderly or older patients, and I use similar sort of kind of things with that. And it's kind of just walk. And then there's steps going up and down onto the beach. It's kind of like, right, that's a big set of steps. You go down them, you walk along to the next set, and then you go up and you walk to the rest. And then we kind of see, because the steps up and down are a completely different challenge for somebody. For me and you, we kind of just take it for granted. We just walk up and downstairs. Somebody who can't do it, it's or not used to doing it. It's a huge challenge.
Yeah, absolutely.
So it's kind of see what's in the environment around you, whether it's parks, beaches, and kind of utilize that kind of thing. So how do you kind of cross over quite a bit between your two professions, between the cardiac rehab and the soft tissue remedial massage kind of stuff?
I've had a couple. I wouldn't say a lot. I've had a couple, just because their posture has not been great, or they felt that they just want relaxing. I mean, that is part of cardiac rehab. We used to do right at the start. We used to have a relaxation phase where we just used to lie people down and play them a nice CD and used to go to sleep. We don't do that anymore. I don't know why we stopped doing that, but
that sounds amazing. Day of work, that just go to sleep for a bit.
Yeah, stress relief. And so no, I don't see anybody. And I've got enough going on.
Do you find that you kind of adopt principles from each, or is it very different?
I mean, I've taken the attitude with both that everybody's individual and they need different needs. One size doesn't fit all. So from that regard, I don't give the same thing to two different people or whatever. That's the same in my clinic because it doesn't work. It might work for
No.
a bit, but long term, it's not going to work because we're all coming to the table with different things and different lifestyles and different ideas. So, yeah.
Interesting.
Yeah.
So if anybody's kind of interested in getting into a cardiac rehab side of it, so I think you mentioned earlier on, so what's the best kind of place to go? Is there specific training providers? Is it NHS trust? Is it?
So like I said, I would contact, first of all, I would contact the local cardiac unit and see what provision is going on at the moment. If there's nothing going on at the moment, I would look at the British Association of Cardiac Prevention and Rehabilitation for their course. Now I say that the Wright Foundation do a course, but in my experience, the NHS and the professionals that are going to be referring into you prefer the BACPR one, just for confidence, because they know, because with the BACPR course, I'm not too sure with the Wright Foundation, you have to revalidate every 3 years.
So it's a good standard, then it's a qualified standard.
Yeah. Originally, when I did mine, I had to go to Loughborough to do the revalidation, and they're doing it online now. But yeah, it's you have to revalidate, and I'm not saying it's not an easy exam.
I imagine it's not. You know, you don't just want anybody working in this that kind of industry, I suppose, do you? It has to be, you know, you need to know what you're doing. Stay up to speed with research. It's the same sort of thing as, you know, STA members of the field. You know, you need to keep up to date with, be evidence informed to a certain degree.
Definitely. And the change, medication changes all the time. Procedures are changing all the time. And the other thing I would do is really try and get a really good relationship with the cardiac rehab team. Because they if you're going to set up your own class as a freelance instructor, they can make or break you, definitely. Because if they don't like you, they're not going to refer to you, and you need them to refer you. I mean, the only other route is to have GPs refer to you. But in my experience, that's just,
GPs don't like referring to people.
awful.
A lot of time.
Yeah, I have to.
I'm not. You know, it's not across the board, but a lot of GPs just, you know, just don't want to. You know, they just send them straight to hospital.
Yeah. Well, I have to send if I do get one from a GP, I have to send the form back at least 4 times because they just don't put the information that you need in there. And I've had arguments with GPs about stuff, and they've just got different ideas, and then they're general practitioners.
I think it's just finding the right GPs, isn't it? You know, it's the same in any profession. You get people who are cooperative and people who aren't. It's, you know.
Yeah. But if someone's got an interest in it, definitely go for it.
So if anybody wants to kind of find out a little bit more about it or wants a little bit more information after the chat, what's the best way to contact you?
On my email, which is mark.fitforlife@hotmail.com.
Okay.
Or phone me on 07973 511 250.
I think I've actually got yours on the buddy list. What I'll do is I'll put a link to the buddy list as well.
I think it is.
Because you're listed in there as well. So I can put your details.
Send my website link as well?
I'll put everything on as well.
Yeah.
So, but it's been a different chat to what I'm kind of used to be honest. It's been good.
Well, I hope that's been enough.
Yeah, it's been brilliant. So thanks for joining me. So if anybody else wants to kind of whet their appetite a little bit more, we've got our Let's Talk About sessions every Tuesday at 8 p.m. with Matt Phillips. All other information regarding the STA, we've got Facebook, Instagram, Twitter, YouTube with all our previous podcasts on. The STA page with a long list of CPD providers, frequently asked questions, and all the information you need to know about CPD on there. Mark, once again, thank you very much for joining me. It's been a pleasure. Take care.
Great.